I'm very pleased to be here. I see we have a big crowd, 130 people so far, and it's a great opportunity to connect with a lot of people. Um, my hope today is I am going to talk about older adults with bipolar disorder. Um, Sage is going to move the slides for me in as subtle a fashion as possible so that it's smooth. Um, and on the one hand, this is a fairly esoteric area that not everybody has a lot of experience with. However, I'm hoping that today um, we can highlight issues that are raised from this specific topic, which is bipolar disorder in older adults, or known as OABD. That's the short form that those of us who have a special interest in this use. Um, but that we can generalize principles to all other conditions from a geriatric perspective. I think what my experience with bipolar disorder in older adults raises are issues that are relevant to all mental disorders in late life. So I hope that that will be um, generalizable in that way. I have in the next slide no conflicts and no financial disclosures. And then there's a slide on mitigating potential bias. And in this case, there won't be any bias because the drug that we're talking about, which is lithium carbonate, is not being promoted by any pharmaceutical company whatsoever, because there's not a lot of money to be made, and that's part of my point in this presentation. I am going to talk today in the next about the objectives you can see here. The first objective is the focus on unique features of bipolar disorder. I'm not going to describe bipolar disorder and the symptoms of mania and depression. I'm going to assume that those of us attending today have a good understanding of what mania is and what depression is. If you want to get into any more specific symptom related conditions, we can do that. But the focus is on what is unique, what is special about bipolar disorder in older adults. You could say the same about depression, you could say the same about delusions. And we're also going to review the clinical evidence that came out of a task force for the International Society for Bipolar Disorder that made recommendations about lithium treatment and other treatments in bipolar disorder. And I'm going to talk a little bit about the use of a Delphi survey and how that works when you have limited evidence to go by. And finally, I'm going to talk about what is, for all intents and purposes, a quality improvement project, which is looking at the practice of laboratories across the country in how they report therapeutic drug ranges for lithium in older adults. So those are my main goals. I should add, I hope that we can have some fun here as well. So OABD, the acronym for older adults with bipolar, what's unique about them? Well, if you look at a group of patients with bipolar disorder who are older, and the question is what's older, usually the age that we cut off for what we consider late onset is 60 or older adult, not necessarily late onset. Late onset is generally considered over 40, but older adults is over 60 for the purposes of this. Let me make it clear that I don't consider 60 to be geriatric. All right, I have a vested interest in that and a special sensitivity to not using the term geriatric to 65 and older. And I know we see this all the time. The elderly are the 65 and over. That is ridiculous. Um, 65 today is middle age, and I consider middle age today to go up to probably 75, which is close to where I am right now. And the reason is that if we consider geriatric to mean frail, if we consider geriatric to mean people who are dependent, who are in need of extra care, or who are cognitively vulnerable, then it does not describe the cohort of 65-year-olds. That doesn't really occur until probably 85. That's a different issue and a different topic. I'm happy to talk about that, but I'd like to get that off my chest. or as a colleague of mine, I'm apparently an expert at mixed metaphors. And a colleague of mine once, after one of my talks, said, Ken, you gave a great mixed metaphor. You said, I've got a bee in my bonnet that I want to get off my chest. So that's what I do. That's what I'm doing. Anyway, so older adults generally have a late onset compared to early onset, right? Early onset is much more genetic. And in older adults, we see less family history, although it is still significant. Genetic vulnerability in this population is still important, but um, not as heavily weighted to genetics as it is in early onset mental disorders. And concomitantly, when you have less family history, we have a higher prevalence of neurological disorders. And that's true of bipolar disorder. This is going to be relevant to the case that we've got to discuss later as well, even though it's not a bipolar case. We're going to talk about that. And the neurological disorders most often associated with bipolar is cerebrovascular and vascular disease. That's an important message here. Vascular underpinnings of many late life disorders is a significant factor, as well as medical comorbidities. So that's a geriatric perspective. We have older adults whose mental disorders tend to occur later in life, less genetic weighting, more neurological, more medical comorbidity. And I think that is applicable to lots of other conditions in late life. In terms of medical, well, let's just look at this picture. Here's just it was a great image of a patient I saw more than 30 years ago. And you can see how dramatic the changes can be in bipolar disorder from a floridly manic, disinhibited man to a depressed, bland looking gentleman. But if you look at the features here, they're consistent with the next slide, which lists the medical comorbidities, which include vascular, cardiovascular, cerebrovascular comorbidities, which includes high blood pressure, diabetes, obesity. That's described that gentleman we just saw, hyperlipidemia, so metabolic factors. This is very common in mood disorders in late life, and especially in bipolar disorders. And all of those things, you can understand that vascular disease in the brain leads to cognitive impairment as well as increased mortality. And the gentleman that you saw in those pictures died within a year of those pictures being taken. So those are the medical comorbidities. It also speaks to the fact that mental health in late life should be intimately connected and integrated with medical care, as well as neurological care. And that's one of the things that we're trying to do in Toronto. We've developed a brain medicine program, a fellowship in brain medicine, where the term brain medicine is an umbrella for specialties that share the understanding and care of people with brain and psychiatric disorders. And bipolar disorder in late life is exactly an example of that. So let's go on to look at practice guidelines. These are practice guidelines that have been published for all ages. This isn't necessarily for older adults. And we were interested particularly in the use of lithium, and I'll show you why. But the recommendation from Clinical Practice Guideline, this is Jin Mali, who's based in Australia, published this in Bipolar Disorders in 2017, that lithium continues to be the first line treatment for maintenance therapy in bipolar disorder. It is strongly used for mania, less effective in bipolar depression, but there's evidence that it reduces the risk of suicide. And the maintenance dose and this, I want you to pay attention to these values. This is what's recommended by the latest practice guidelines, 0.6 to 0.8. It's a bit of a narrow range, frankly. Hard to keep people in such a narrow range. But just remember those figures, because we're going to go back and look at laboratory reporting for lithium in older adults. And they were not a geriatric task force, but simply recommended, quote, lower levels for the elderly. But in the next slide, you can see what's happening with lithium. It's recommended as the first line treatment. It has a lot of positive features like suicide prevention. And there is evidence also, by the way, that there might be neuroprotective features with lithium carbonate. But compared to other classes of drugs, especially antipsychotics and benzodiazepines and antidepressants and divalproex, all of which are being promoted by pharmaceutical companies, lithium is being prescribed. Now, this is 5 years old, but I'm sure that this is the case today. Lithium is being prescribed at a much lower rate, despite the fact that it's recommended as a first line treatment. So here we have a concern, and again, a generalizable concern. Drug prescriptions are being influenced by marketing. Drug companies are promoting the drugs where they make money. Nobody is making money off lithium, and it is up to us as clinicians to ensure that it is being used properly. When we look at older adults, Sage is doing a tremendous job here of anticipating my next slide. There's very little evidence base for treatment of older adults with bipolar disorder. There's a study called GERI-BD, or geriatric bipolar disorder, that was published several years ago, a multi-site study, but it was for acute mania. And there's very little guideline for maintenance in older adults. So in the next slide, you can see what the concerns are. Do we need to be concerned about lithium in older adults compared to younger adults? And again, this is generalizable to other drug treatments, but here are some specific issues that we need to pay attention to in the elderly. Remember, elderly being probably over 80, but in this case, we'll accept 60. Lithium is excreted exclusively by the kidney, and we know that normal aging results in decreased renal function. So pharmacokinetics of lithium is important because it is being excreted at a lower rate and lower efficiency than in younger people. And so that is another reason that lithium levels creep up with age. It is also sensitive to certain drug interactions that increase lithium levels, and these are commonly used drugs. And here's a very important point, easy to miss. One of the biggest problems, of course, I'm extolling the benefits of lithium, but drug interactions and drug toxicity are some of the greatest problems that we see in old age. So lithium interacts with a number of very commonly used drugs. It includes drugs like diuretics, thiazide diuretics, right? Even furosemide. It interacts with non-steroidal anti-inflammatory drugs. ACE inhibitors. These are commonly used drugs, and that's a big problem because people who've been on lithium for many years, as they grow older, will often be prescribed these drugs, diuretics, anti-inflammatories, ACE inhibitors for blood pressure. And when these drugs interact with lithium, you increase the risk of toxicity. So they're vulnerable from both a pharmacokinetic and a pharmacodynamic perspective. Lithium as a side effect can produce Parkinsonism. And this is a problem. I'm going to show you this in the next slide. And we've talked about the neuroprotection. So first of all, let's just describe what does lithium toxicity look like. So when people get toxic on lithium, when they develop side effects, it can affect multiple systems. So you can get gastrointestinal systems, diarrhea, in severe cases, vomiting. When you get nephrogenic diabetes insipidus, that is inhibiting the reuptake of lithium in the tubules, you can get polyuria, you're peeing a lot, and in compensation, you're drinking a lot. It can cause cognitive impairment. It can cause tremor. That's very common with lithium. And it affects balance, and in extreme cases can produce falls. And as I said earlier, it can produce Parkinsonism. So these are the symptoms of toxicity. Why is that important? Because these are common symptoms that can occur. And it leads to what has been described as a prescribing cascade, which in the next slide shows you what I mean. Prescribing cascade simply means that when drugs produce side effects that are not recognized as side effects, but are considered new conditions, you end up with additional drug prescription, which only aggravates the problem. It's a cascade of drug toxicity. So, for example, If you get Parkinsonism with lithium because of tremor or actual Parkinsonian symptoms, including rigidity, but they're secondary to lithium, if it's not recognized as a side effect, it's very likely that these people will get prescribed dopaminergic enhancers like Cinnamon or L-Dopa. So all of a sudden, you've got somebody who's on lithium, who's getting toxic, and now instead of having the lithium reduced or recognized as toxicity, they're given another drug that can make them even worse, namely Cinnamon or L-Dopa. If their cognition is impaired because of toxicity, they could be misdiagnosed as suffering from dementia and end up with cognitive enhancers, which they don't need. And if they become apathetic or apparently depressed, then, of course, you can get antidepressant prescriptions, which are not the best idea, of course, in bipolar disorder because of the risk of switching. So I hope you can see that there are real dangers in the use of drugs that cause side effects. And this is true of all drugs, not just lithium. So without the evidence for lithium, several years ago, we decided to do what's called a Delphi survey. That is, we didn't have good double-blind, placebo-controlled trials to tell us how to use lithium in old age. So what do? The next best thing was an expert survey. We decided to survey people who we considered experts in the field based on clinical experience. And Frank, that's what we have here. This national community of healthcare professionals is a good example of that because clinical experience, shared experience is very powerful. And that's what a Delphi survey taps into. In some ways, I actually think this might be more valuable than a rigorously controlled, double blind, placebo controlled trial that is not necessarily generalizable. It's not reflecting effectiveness, it only reflects efficacy. You can prove through a double blind, a randomized controlled trial whether the drug is efficacious. That is it better than placebo in the acute phase? But is it effective? That we don't know because that depends on clinical experience, tolerance, long-term use. So we decided to use the Delphi survey, and it uses iterative questionnaires to come to a consensus. And in the next slide, we describe the methodology that we used. In a Delphi survey, first of all, you have to identify the experts, and that's a task. You have to who's genuinely to be considered an expert. But we did that through other mechanisms. You begin with open-ended questions. What would you use for the treatment of bipolar disorder, rather than asking focused questions at the outset? And with each iteration, and there are usually at least 3 repetitions of the cycle of questioning that gets increasingly focused with each iteration, you can narrow down the questions to give specific answers, which I'm going to show you. You invite comments from the group. You have a committee, an oversight team that reviews the answers, that formulates the results and the questions, and prepares the next set of questions. And so we did this with 3 iterations in a group of 25 experts around the world. The goals of our survey were to identify the preferred choices for maintenance treatment of older adults, to determine where lithium fits in among those choices, and to try to provide some guidelines for the safe and effective use of lithium, knowing what we know about the unique features of lithium in older adults. We had secondary goals of the survey. We were looking specifically for what the therapeutic range would be in older adults. And we also differentiated, as I just did earlier, the young old, 60 to 79, who I would actually reclassify as late middle age, and a true group of older adults who are 80 and over. I think that's a more appropriate labeling. So we have the young old and the old. And we also wanted some guidelines for the laboratory tests that we need to use when we do use lithium, as well as clinical assessments. So those were our secondary goals. And the result was overwhelming. 100% of the experts said that lithium is the preferred choice for maintenance therapy. 100% of medical experts said that, notwithstanding that the use of lithium is dropping like a stone in the real world. And why is that? Of course, we talked about that. Lithium, doctors are afraid of lithium. It's not being promoted by drug companies. The less experience they have, the more they avoid it. And lithium can genuinely cause toxicity and problems, especially because of the way it's being used, or it has been used in the past. So in the next slide, we asked the question, well, let's move on to the second line choices. Are not as, these are the commonly used drugs that we all see in mood stabilizers, valproate, lamotrigine, quetiapine, olanzapine. They're not without their problems, of course, these drugs, especially in terms of metabolic side effects. But in the next slide, we ask the question, does your lab report separate levels for older adults? So knowing what we know, that lithium excretion decreases with old age, that lithium can cause side effects, there are drug interactions, surely we should be using separate levels for older adults. But no, 100% of the labs said no, they do not report separate levels for older adults. So this was a problem. But what did they report? And look at the lab values. Remember I showed you the recommended value. This is for all ages, was most recently 0.6 to 0.8. This is what the labs that the experts who were in the survey, their labs were reporting these ranges for lithium, therapeutic ranges. And look at the upper range, 1.2, 1.3, one lab 1.5, when the recommendations for general use is up to 0.8. So you see there's a serious problem. Suddenly you can see why drugs are a problem in older adults, because we're not using them properly. The laboratories, which people rely on and trust, are recommending levels, so-called therapeutic levels, so-called normal range, that is in fact toxic for most older adults. So no wonder people are afraid of lithium. It's been used in a way that promotes toxicity. And that became a big concern for our task force. And what were the recommended ranges? And here you can see that they're similar to what was recommended in the general adult population. The 0.4 to 0.8 for 60 to 79-year-olds, who are more or less like the general population. Interestingly, for the 80 and over, I thought we'd have even lower levels, but the consensus was 0.4 to 0.7. It was only slightly lower in the very old. But that's the kind of range that the experts recommended, in contrast to the range that was being reported in the labs. Lab testing, I don't want to go into details. I know we only have a few physicians in the audience, so the lab testing is less critical, but we actually had recommendations for testing of lithium levels, creatinine because of kidney concerns. In the next slide, we recommended thyroid, calcium, cholesterol, metabolic screening. These are the standards for lithium at all ages, of course, but especially concerning in older adults where vascular disease and toxicity are a problem. And in the routine clinical assessments, we recommend, again, depends on how frequently you can see a specialist, and depends on where you are in the country as to how frequent that can happen. But tremor, gait, cognitive screening once a year, we recommended using either the MMSE or the MoCA now being more common, more popular, and neurological assessments only as concerns arise. So those were the recommendations. And we were left with some outstanding questions. In the next slide, we still don't know really about the long-term effects of lithium on kidney function. This is an ongoing concern where lithium it's certainly at toxic levels, it will damage the kidney. Whether at therapeutic levels it damages the kidney is another question. What about the metabolic effects of lithium and atypicals in older adults? There's some question that actually lithium may be neuroprotective. Maybe it's a good thing to give people lithium. There's some evidence that it may protect from dementia. But we need guidelines, not just for lithium, but for other treatment. So in summarizing the findings of the Delphi survey, make it simple. Lithium is the preferred choice, but of course it's not being used. The target range has to be much lower than the labs are currently using. So with that, we moved on, and I'll just try to summarize this quickly in the last few slides, to a quality improvement project involving the laboratory. So if the labs are recommending toxic levels of lithium, we have an obligation, those of us in the health community who know something about the use of lithium, we have to stop them from recommending levels that are toxic. And so I teamed up with laboratory medicine colleagues at Sunnybrook and more recently across the country. And we looked at some data that laboratories. So in the next slide, you see the data from the Sunnybrook lab. And at least at Sunnybrook, where I work, you can see that by age, going from left to right, youngest to old, that the levels for older adults are very low at Sunnybrook. But in the next slide, you can see that we did a survey using the Canadian Society of Clinical Chemists saying, how do you measure lithium? Do you use older adults? And finally, here's the results. The last slide that I'm going to present are the results from 21 labs across the country. And you can see that only a third of them provided age-specific ranges. But look at the list. The upper level of normal therapeutic range is still way too high, 1.4, 1.3, 1.2. So our job now is to work with the labs across the country and internationally to lower the recommended therapeutic ranges based on this work. I'm going to stop there and we can move on.